Hello everybody. Today we are going to discuss about the augmented renal clearance. So antimicrobial treatment in patients with the infection and sepsis is challenging, especially when these patients are critically ill. The specific challenges in the critically ill patient are both patient as well as the drug. There are alteration in the drug pharmacokinetic due to greater volume of distribution, hypoalbuminemia causing decreased drug binding, leading to the altered level of the free drug in the plasma, ICU procedures like renal replacement therapies, and the hepatic and the renal impairment, leading to the increased plasma drug level. So, the usual objective in assessing renal function in critically ill patient is to judge the degree of the renal impairment and to adjust the doses and the frequency of drug accordingly. However, the reverse, that is, increase in the renal clearance of same drug, may be true in some critically ill patient. This enhanced clearance of the drug from the plasma or augmented renal clearance causes suboptimal level of the drug or may be cause for failure of the clinical response or development of resistance to the antimicrobial drug. In this situation, understanding and the application of pharmacokinetic and pharmacodynamic principle of drug will lead to the increased clinical success and decrease adverse event and the resistance to the antimicrobial drugs. Now about definition, augmented renal clearance is defined as measured urinary creatinine clearance of more than 130 ml per minute per 1.73 meters square. It may be seen in 20 to 65% of critically ill patients. It is more commonly seen in certain subset of the critically ill patient, that is subarachnoid hemorrhage, traumatic brain injury, burn, sepsis, and hematological malignancy. Other factors associated with augmented renal clearance are young age, diagnosis of polytrauma, and lesser severity of illness that is defined by lower Apache and the SAPS-2 score. Now, mechanism of the augmented renal clearance in the critically ill patient. The exact mechanism is unknown. Augmented renal clearance is proposed to be due to systemic inflammatory response syndrome. In patients who develop systemic inflammatory response syndrome, there is increase in the glomerular filtration rate due to increased cardiac output and the decreased peripheral vascular resistance due to cytokine and inflammatory mediators. The use of fluid and the vasopressors or inotropic drug in this patient also potentiate this phenomenon. All these factors lead to the increased renal blood flow and the increased GFR. Another mechanism of ARC may be increased functional renal reserve, which is defined as ability of the kidney to increase GFR in response to certain stimuli. The combination of these two mechanisms is most likely to be present. Now, impact of ARC on the antimicrobial treatment. Augmented renal clearance in the critically ill patient may lead to the non-attainment of therapeutic level of drug administered to this patient, that is antibiotic, anticoagulant drug, and antiepileptic drug. This is especially true about hydrophilic antimicrobial drugs, which is mainly cleared by kidney, that is beta-lactam, vancomycin, and aminoglycosides. Antimicrobial drugs are classified according to their activity pattern into three, that is drug with the concentration dependent elimination of the bacteria with prolonged post antibiotic effect, that is aminoglycoside, fluoroquinolone, daptomycin, polymyxin, and metronidazole. Drugs with the concentration independent elimination of the bacteria with a prolonged effect, that is tetracycline, tigecycline, trimethoprim, sulfonamides, macrolide, clindamycin, linezolid, vancomycin, and chloramphenicol. Drugs with the time-dependent elimination of the bacteria with no or very short persistent effect, that is beta-lactam. So the PKPD indices, which are best correlated to the efficacy of antimicrobial drug, are maximum drug serum concentration or minimum inhibitory concentration ratio, or area under concentration time curve, or MIC, for drugs in group 1 and 2. So for drugs in the group 3, the period of time which that is time free antimicrobial drug level in the plasma is more than the MIC is best correlated index. In critically ill patient in whom augmented renal clearance is present, the enhanced clearance of antimicrobial drug will lead to the shorter half-life of the drug, reduced Cmax, and the smaller area under curve of the drug. This lead to the decreased effectiveness of antimicrobial drugs. augmented renal clearance, and the vancomycin therapy. Area under concentration time curve or minimum inhibitory concentration of more than 400 is associated with the best efficacy of vancomycin. In study of 93 septic patients treated with vancomycin by continuous infusion, augmented renal clearance was found in 40% of patients, and these patients had 25 to 30% lower concentration of vancomycin in their plasma. Another prospective study in the critically ill patient found augmented renal clearance in 27% of patients. All of these patients had the lower vancomycin plasma concentration level during first 48 hours of starting treatment with the drug. These patients require higher doses of vancomycin to reach therapeutic plasma level as compared to patients without augmented renal clearance. Now, augmented renal clearance and the beta-lactam pharmacokinetics. The PK/PD target of beta-lactam antibiotics are time more than the MIC of 40% to 70% of dosing interval, or plasma drug concentration more than 4 times of MIC for entire dosing interval. In study of 48 critically ill patients where trough level of beta-lactam were measured, ARC was associated with lower PK/PD target in almost 80% of patients. Hence, these patients required higher doses of beta-lactam drug to achieve adequate therapeutic plasma level. Antibiotic regimen should be individualized according to the presence and absence of augmented renal clearance, and these drugs may be given in the form of extended infusion. Augmented renal clearance and the clinical outcome. There are very few studies correlating augmented renal clearance and the clinical outcome. In a prospective observational study of 128 critically ill patients, 52% had augmented renal clearance and treatment failure was higher in patients with augmented renal clearance. Two other studies found no correlation with ARC and clinical outcome. Evidence to correlate augmented renal clearance with clinical outcome may be difficult to come by due to complexity and variability of critically ill patients. Thank you, guys.